Thank you very much, ladies and gentlemen, for joining us today on this Zoom video conference and information session. I am just acknowledging we have about 57 participants. And my name is Drew Ferguson, the Public Media Relations Coordinator for the Grey Bruce Health Unit, and I'll be the moderator for this session. Joining us from Public Health are Medical Officer of Health, Dr. Ian Arra, and Environmental Program Manager Andrew Barton, and from Bruce County Warden Mitch Tulin. And following my introduction, the format of the meeting will begin with opening remarks from Dr. Arra, who will provide some additional context with respect to the Stage 3 opening and as it pertains particularly to the municipal sector. And from there, we'll address the many questions that we've received. I've tried to group them in various themes and of a general nature. And some of the questions are a little more site-specific, which may not lend themselves to this forum, but hopefully we'll get through them all anyway. And if you wish, you can add some questions using the chat function on the Zoom screens. Those joining by phone, unfortunately, will not be able to ask questions. That means, but we will see if we can link them in by phone. If time does not permit all your questions, I'm going to ask you to please use the Contact Us page on our website, send the question, and we'll respond to all inquiries. And that may also apply to any questions you got related to your own circumstances. The email is publichealth@publichealthgraybruce.on.ca, but simply going to our webpage, at the bottom of the webpage is Contact Us, and that gives you the link. The session is being recorded and will be available on the Grey Bruce Health Unit YouTube channel. Link will be provided as soon as it's available. And as you know, we are in the about the third week of opening of Stage 3 for a number of sectors in the province, including Grey Bruce, and a number just are joining Stage 3 today. And to get underway and take us through Stage 3 reopening in Grey Bruce, it's my pleasure to introduce the Medical Officer of Health, the top doc, Dr. Ian Arra.
Thank you, Drew. Thank you, everybody, for your interest and attendance. I just want to start by thanking everybody around the table for the great effort you have invested over the past 4 months to allow all of us and our community to have the relatively positive results that we have comparing to any part of the province and other parts of the country. We continue to have 0 death related to COVID. That's 0 death, and that's directly related to the effort you have implemented by virtue of your position being a leader in the community. Many people emulate, and I have no doubt that the fact that you have been informed, concerned, engaged, not afraid, has allowed many people to emulate and follow. And for that, you know, it's a collective effort for all of us, and I want to thank you for this. I'm going to share my screen, Drew, for the slides that I had presented to the Board of Health and different partners about the reopening of Grey Bruce, or safe reopening. Can I get confirmation that you can see my slides, Drew?
They're there.
Thank you. So, safe reopening of Grey Bruce, there are around 20 content slides that will take us 15 minutes to go through. Disclosure, I have no relationship to anything commercial or private or any potential conflict of interest. The private sector does not even know I exist, other than from being the Medical Officer of Health. Objectives of this session is to provide better understanding of the process of safe reopening and answering questions like Drew mentioned. So what is safe reopening? Really, to understand this, we need to look at the emergency from a bit of distance. If you look at it from public health, preventive medicine specialty point of view, or the practice of public health, it has 2 components: the mitigation, which was March and April to have full control over the outbreak, then the reopening. And most people think the first one is the most difficult. Actually, it's not. The second one has more challenges. The first one is a clear objective. Let's minimize the number of disease and cases and death from COVID until we have control over it. and that was done nicely in Grey Bruce. The second part of the emergency management is reopening. And in the reopening, we have two objectives at the same time, and they're actually somehow opposite of each other. We need to minimize death and disease from COVID, and we need to minimize death and disease from measures against COVID. Herd immunity would be the ultimate silver bullet we're all looking for. That could happen through a vaccine or different approaches, and I'll mention them in the next slides. So the measures against COVID, we know what they are. Social distancing, we've done them in March and April, control the outbreak. However, these measures have a cost if they go for a longer period of time. And that's why our goal is to reopen as fast as we can, as long as safe. And some of the intuitive prices that we pay for measures against COVID is mental health, domestic violence. These cause disease and death, potentially, if gone for long. Heat waves is another one that might not be intuitive. However, it's going to be a reality for us to deal with during this summer, similar to other summers, especially for the lower socioeconomic status, people who cannot afford air-conditioned residence, air-conditioned environment in their residence, usually depend on cooling stations and such as libraries, grocery stores. And we know in COVID, this becomes an extra challenge. The economic impact is paramount. We know economy is the #1 determinant of health. You Google any public health agency social determinant of health, and you will find top that list. What determines health is income. And that's why we need to open as fast as we can to ensure economy would flow as long as it's safe again. So lessons learned from other countries. In Asia, they applied public health measures like we have, and really their experience has been positive. They have control over the outbreak. Nevertheless, as soon as there is no introduction of a case in the community, the risk of the virus is still there. And many people think often, we already controlled the outbreak, so we're done with this virus. The fact of the matter, the virus is not done with us, and we need to keep our guard up. It's not the time to lower it. In Europe, the experience in Sweden was a bit different, where they gambled on herd immunity. More or less, let's burn it through, and we were going to get the 70% of the population immune, and that's going to control it. Well, what happened about, when the results start coming out around 5 weeks ago, it's as early as late May or mid-May, the result there was increased number of cases and death. So if you compare Sweden to the closer 3 countries in Scandinavia, Denmark, Norway, and Finland, that they have the same social fabric and habits, in Sweden at the time had 4,000 deaths, while all the other 3 countries combined had less than 700. So they had more cases and death. Did they reach the herd immunity they were aiming for? They didn't. Actually, they reached around 6 or 7%, far from the 70%. So you look at the lessons from the United States, it goes without saying. People know that the measures that we implemented have not been utilized there fully, and for multiple reasons, they end up with different results from us. Herd immunity is the ultimate goal. That's where we will control it. And the vaccine is the silver bullet we're looking for. Measles is a disease that was, back in the day, as scary as COVID, claimed many lives. And as soon as a vaccine was found and given to the public, measles became a disease that even physicians don't see in their training or their career. The dynamic physical distancing to say, let's shut it down, open it, shut it down, open it. A nifty idea, however, in practice, probably will be detrimental to both the control of the outbreak and the economy. Uncontrolled outbreak, that's what the Swedish experience was. Hammer and dance is an approach to say, let's close it for 6 months, and when it's open, it's going to be gone. Again, theoretical, not practical, have not been applied. The first approach, phased lift restrictions, is the approach we have in the province and in Grey Bruce, and that's what's supported by the science to be implemented. In this approach, you would see that we looked at, these slides were put together actually late April, early May, even before the province started opening. And our team has been working on the reopening stages when we were at the end of the mitigation stage. The variables that we control or observe, monitor for going forward during the reopening are these 3 sets of variables, and there are many more within. The virus spread, which is the epidemiology, number of cases doubling times, others, system capacity, how many beds in the hospital, how many healthcare, and the testing capacity. And it's not the number of tests per se, it's rather the readiness for testing and how soon the test can come back. And you can appreciate in Grey Bruce, the healthcare system and the capacity to treat has been there, and we're grateful for their readiness. However, they have been our insurance policy, similar to the car, auto, or home insurance that we buy. We hope we will never use, and in our case, we have not used so far. There has been only a couple cases hospitalized and 0 death. So there will be 3 phases, as you know now. These slides, again, were prediction of what the province will put forward, and this has been a very successful prediction and useful because it allowed businesses and organizations to be prepared for what's coming, and we were able to hit the ground running when we got the green light from the province. There are 3 stages, and we classify activities, businesses, organizations in each one of these. And that's not based on, dislike of the MOH, rather it's based on assessment that would include many variables. The most important 3 sets are the number of people in activity, the time spent, interaction among individuals, and the ability to modify that activity. And these variables are the same principles, how you can mitigate the risk in your organization, or you can provide advice to even individuals, how they can reduce their own risk. A concrete example that can bring this to a better understanding, or you can wrap your arms around it as a principle for mitigation, is looking at 2 types of businesses. One of them is golf courses on one side of the spectrum in the early stages of stage 1, and the second one is bars and movie theaters that would be definitely in the 3rd stage, like you have seen. And it's based on risk, based on these factors. Golf courses, you would find small number of people in a big space, and the interaction among them time-wise is minimal. They don't have to be touching each other. They don't have to be like a dentist-patient relationship in contact for a period of time. Rather, it is people walking on a golf course, as you can appreciate. The ability to modify, there is all the ability to modify on a golf course. There is a space, and there is really no need for interaction. If you look at the other side of the spectrum, bars and movie theaters, large number of people in a limited space, and they spend lots of time together, and there will be limited ability to modify, because if you space them out in 2 meters, the whole bar can hold only 10-20 people. So it's not going to be business, not going to be ability to leave the business afloat, or the whole activity really is not going to be meaningful, because people go to bar to enjoy music in a loud situation with many people and mingle and talk. And all these activities actually have risk to them. People touch the same surfaces, people talk over loud music, which more or less is yelling, similar to coughing. Singing is another activity that's high risk. And that's why we have bars and movie theaters really late in in the stages. Movie theater, there isn't much talking, but it's longer space, amount of time in a smaller space, lots of people. So we had classified businesses based on contact intensity, number of contacts, modification potential, as I mentioned. Then there were a few questions to be answered. Who would decide? It's the province. The local MOH cannot override a direction from the ministry. We can always restrict if the need be, but in our case, we really have been ready to open before the ministry gave us the green light. Implementation with every stage, we cannot just say this stage is successful before we go into 3-4 weeks and we have no increase in epidemiology and other variables would stay constant. So we continue to the next phase. If we're not sure by the end of 3-4 weeks, there are a number of cases. However, we can't tell if it's high or low comparing to the other epidemiology baseline. We lengthen the phase. And if we have a surge of cases, we retreat to the previous case. So that's the base of it, and the 3 to 4 weeks is based on the incubation period of the virus, 5 to 14 days. Then symptoms would develop, then a person will be tested. So it takes 3 to 4 weeks to see any result of any intervention we have today. It will take us weeks, 3 to 4 weeks to find out the result. So if you want to implement measures in your organization or in your personal life, what is more effective? What's the hierarchy of control? And this comes from evidence from Johns Hopkins, one of the most credible public health schools. Physical distancing is king. And you can see the upside pyramid. This is where the money is, the 2 meters. And 2 meters is not by any means a magical number. Over 2 meters, I'm protected. Under 2 meters, I am doomed. No, it's just a spectrum. The closer you get to a person and the longer the amount of time you spend with them, the higher the risk is. But if you want to implement measures in a workplace, physical distancing is most important. Engineering controls are also effective, less effective, but they are very effective. One example is the shield at the front desk when there's interaction with the public or with a group of people. Administrative controls, including policies that you would have for cleaning and frequency of it. The policies that cleaning will happen at night, not when there are people, to minimize contact. PPEs, masks are effective. However, in the list here, they are least effective. And their efficacy is around 5 to 12%, rounded number, 10% protection. So if we have 100 cases in the coming 2 months, if nobody wore a mask, if everybody wears a mask, we will get 90. On a societal level, that's really good result. But again, I really want to emphasize this point that PPEs, wearing a mask, sometimes give a person the false reassurance they are protected, and they might take more risk and touch more surfaces or spend more time or get closer to other people. And that should not be the case. These 4 interventions or sets of interventions should be combined, not one replacing the other. Role of the health unit to support you in many ways. Communication, the last one, is probably one of the key components, and we have a communication team that has done amazing work in ensuring people get the fact, not the fiction. People can protect themselves. To be concerned but not afraid, again, providing enough information not to frighten people but to get them engaged is a very delicate balance that I believe has been achieved nicely in the past few months. We have capacity to contact, case management and contact management. And these are, to many people, just words. These are very complex protocols, and they're being deployed in many ways. And we have been able to ensure zero transmission to co-workers or to clients if the case was in a workplace. So yes, these follow cases and find their contacts, and we provide the information and the advice or the requirement to testing for these people, but they don't just exist in their home, they exist in workplaces. So we have been managing workplace COVID investigations. with every case that we had in Grey Bruce. And again, the track record of no further transmission. The only exception was a long-term care where there was a lot of dementia in proportion of people with dementia. So it was really difficult to control that. However, the final outcome was 0 death in that facility too. And that was directly related to the expertise of the healthcare worker in that facility and the infectious disease team from Grey Bruce. So what would happen if you know that there is a case in your workplace? I want to reassure the group that we already probably dealt with it by the time you know about it. By definition, any case identified by a lab in Ontario, if the residents or the patient resides in Grey Bruce, we would be the first to receive the result. Within seconds, I've audited a couple of processes. Within seconds from the lab identification, we receive the electronic result. We follow up as soon as we can. The target is 90% of cases need to be followed within 24 hours. We still maintain the track record of 100% within 24 hours. And if it is a sensitive workplace, long-term care or high-risk aggregate setting, we will follow up within minutes. And again, the contact management and case management will be conducted. It's important to know, although we operate in the public arena, we ensure privacy. So if there is a case in your workplace and they have 4 contacts, that means 5 people will go home to self-isolate for 15 days and get medical treatment. As an employer, you might not know which one the case is. All you would know that 5 people left the workplace. One of them is a case, the others are contact. However, none of them even would know who the case is unless the case themselves release that information. And we have noticed or found that in as you would appreciate, small communities, people talk, and the word will come out, and some employers would have policies for the employees to disclose to them, which is really not the norm. There's no difference between meningitis and COVID. Even meningitis is a worse disease, a more severe disease than COVID. And in normal days as employers, you wouldn't even ask what the diagnosis was. You only know that somebody left for medical condition. And that is set with a system in the background, ensuring that person is followed. So by the time somebody disclosed to you that they are a case, our team has already contacted everybody who needed to be contacted. So if one of your employees did not get a call from public health, that is a very good day. That means their risk is not there, and that's why we didn't call them. People who had risk already been called, and that will be done within hours. We would always have the courtesy, not just the courtesy, the better practice to communicate with you if there is potential of splash in the media or anxiety in the community, to give you a heads up that this might come your way, that there is one of the cases in your workplace. We will not be releasing the private information unless, in certain circumstances, collaboration with the employer would allow us to track people faster. So if we cannot find somebody, but we know that they worked with 3 people, we will call you and say, can you let us know who the 3 people or people who worked with that person? And again, to reassure the group, 0 transmission to coworkers in any workplace. And that would include grocery stores, big outlet restaurants, hospitals. There was one suspect outbreak in a hospital where there were 2 cases, and the investigation was complex to have 4 components, 2 in the community, 1 for the patient, 1 for the healthcare worker. Both of them were infected, and their families and friends were followed. And within the hospital, there were over 90 contacts. We assessed the risk for all of them. We only tested 7. So again, having a case in your workplace does not mean the sky is falling and everybody's infected. It's not. And usually people will be inclined to do cleaning. And the term deep cleaning has come to the media a couple of times, that a restaurant shut down and they're doing deep cleaning. There's no science behind deep cleaning. The virus is not hardy. Any type of soap or disinfection, regular bleach would destroy it. And there are recommendations on our website, lots of material, what you need to do for cleaning. And cleaning should be continuous, but it really should not come after the case happened. When the case happens, by definition, already 3-4 days went by to get the result from the lab, and the virus only survives for 24 hours. So by definition, any virus left in the workplace is already destroyed by time. There's no need to do deep cleaning after finding a case, or to do any cleaning. Now I'm using the word deep cleaning. There are plenty of resources on our website, and I would really advise you to spend 5 days a day or so to see what's new. And there is a section for businesses and organizations. You would find, from the experience I had with many people referring to them to this link, universally I would say I found all the answers I needed. And if there is any answer that's not needed, please connect with our helpline. Our team is here to help you with answering these questions. Those are the references, and I'll turn it to Drew for questions. Drew, I seem I took a bit longer than I expected, but I suspect what I mentioned answered many of the questions that were already there.
Yes, indeed. Certainly quite a few of the early questions in terms of what recovery looks like and how we move back and forth through the stages were some of the early questions that were addressed in your presentation. So I think I'll move to some of the business and office setting questions, which may pertain to most of our audience here today. And so to begin with, what is your recommendation if you cannot physically distance in a municipal office setting?
So in a municipal office setting, there usually the ability to have the 2 meters. The number of people who work in offices are limited, and there are boardrooms able to hold meetings. The health unit is the same setting. However, if you're talking about a corridor or a kitchenette where people might be gathering, wearing a mask, frequent cleaning, maybe having different times for people to attend that space would reduce the number of people at one time. All those mentioned in that upside pyramid would be useful, and the more you can do of them, the less risk there is. If people are passing each other in corridors, the window of time of interaction is really minimal, and the risk is not there. However, if people feel that they have comorbidities, heart or lung disease, or any other vulnerability, or because of age, wearing a mask would always help a bit more. It usually helps people around the person wearing the mask, but you know, we wear a mask to protect the others, and the others would wear masks to protect us if there are these situations where there are multiple people in place. At the front desk, where the public can be, and there is no control on how many people can be at that time at one time, wearing a mask and again cleaning any surfaces that are frequently touched will be very useful. Having passive screening at the front door or active screening to ask people for symptoms or put a sign reminding them of the symptoms and they need to not enter if they have these symptoms, another layer of protection.
Following up to that, if an employee tests positive for COVID-19 in a municipal setting, what else will happen in that municipal setting, and who are considered close contacts that may be requiring further action?
So in case of a diagnosed case, by definition, we will notify that person of the diagnosis, and we'll guide them through what they need to do, self-isolate and get treatment. And we will compose a list of who the close contacts are, the people that met with this person in the past days where they potentially was exposed to the virus, or they provide or they pass the virus to the person. And we call them the source case. That's where the virus came to the person who's infected, or the secondary cases. We do this in the background, and we do it really quick, and we would notify everybody. And when we notify them, we don't mention the name of the case ever. We always pass that information as you have been exposed to COVID, you need to do these things. In the workplace itself, really there isn't, in general, need to do much. The person, by the time they got their diagnosis, 3-4 days went by. So there is no need to go and shut down the office or clean the office. Cleaning of the office should be continuously, especially if somebody left for illness. If somebody got to work and realized that they're spiking fever, they would leave. By the time they leave, that station where they worked or that office should be disinfected. That would be appropriate time to do it, but that would come before the diagnosis of COVID has taken place. It could be any disease. However, we need to prepare for the worst. If there is risk to people in the facility, in the workplace, we will mitigate it directly with these people. If the engagement of the employer is required through the investigation, we would do this. In general, the employer does not have to do much about a COVID contact tracing or management. And again, there was a couple errors where people want to do more and they actually breach the confidentiality of the employee, and they created some anxiety in the community where many people went to the assessment center to be tested just because they were in that place, although they have no real risk. And the bottom line to this, and it could be very assuring to your staff, to the group, to the community, if people did not receive a phone call from public health, it's a good day. Their risk is not there, and they should not be concerned more than any other person who's concerned in a pandemic.
Dr. Arra, some organizations are using screening as questions to their staff as they enter the municipal offices or whatever, and they're wondering what should be required if someone answers positive to a question such as having cold or flu-like symptoms. Should they be required to stay home, and if so, for how long? And how do you extract that from somebody who simply has allergies?
So the advice to anybody who tests positive on these screening, and they're very important screening, and it's a good practice, the advice would be to seek clinical care, to seek testing, to stay home, isolate, and connect with their healthcare provider to find out what the situation is. And like the question rightly pointed out, it could be allergies, it could be COVID, it could be anything else. It's not on the employer unless that they are a healthcare provider. It's as a family health team or a hospital, they have the capacity to distinguish. As municipal offices, you wouldn't, so the advice would be to seek healthcare.
Okay. One more quick question with regard to the office setting, which also applies kind of to retail as well. Should municipal offices be accepting cash payments? And if so, what sort of protocols should they have in place?
So there are many measures to reduce risk, even with using cash. It's preferable to use electronic payments so there is no handling of money. As we know, the money is a surface, especially the Canadian money, it has plastic surface to it, so there is potential of transmission there. If they must use cash, it could be to use complete payment without change or return and back and forth of change. It could be deposited in a certain spot and left until 24 hours went by. Hand washing is key, and I will ask Andrew to provide a bit more tips there, because this question was well addressed in when we opened farmers market, where cash could be a potential of transmission.
Yeah, to be honest, Dr. Arra, I think that's a pretty thorough answer. Obviously, for some environments, perhaps farm gate sales, that kind of thing, they pretty much do have to have cash sales. In this municipal environment, it might be that quite a lot more can be done electronic, which obviously would be ideal. But as you say, where cash sales are required, sort of limiting the back and forth, limiting the interaction, hand hygiene, of course, before and after, and yeah, that sense of perhaps leaving if you can before doing a tally. Obviously, once you've got 24, 48 hours, then really the risk becomes very low at that point.
Anything further on that, Dr. Arra?
Oh, that's as Andy mentioned, he led the project on that subject, so his answer would be very complete. The risk of transmission on surfaces, the recommendation has evolved. Early on in a pandemic, it was more conservative to say 24 to 48 hours based on the presence of genetic material of the virus on surfaces, especially plastic and metal. There was evidence of 24-hour trace. However, the most recent studies or recommendations are showing that although you can find the genetic material of the virus, that genetic material is not able to replicate, so it's not able to infect. And 24 hours could be probably a conservative estimate for infection.
I'm going to turn the questioning over to the issue of masks, as there's a lot of questions on facial coverings, particularly why now and not previously, and then following that, how long can we expect this wearing of masks in public places?
All good questions. So wearing a mask in public places as intervention to reduce transmission in a pandemic is not a new idea. It is in a pandemic plan. It is in a pandemic plan of many municipalities to be used. The appropriate time to use it depends on certain variables, the most important two of which are the evidence of community spread and the interaction among people. These two things need to be in place to pull the trigger on this intervention. So if you concretely go back to January, February, I spoke to the Board of Health and the two county councils saying we need to dust off our pandemic plan. This is coming our way, no way. In all cases, it will hit us. If we issue masks at that time, it will be futile because there isn't community spread in Grey Bruce. So the first factor was not met, or criterion was not met. If you go to March and April, there is community spread. However, there isn't interaction among people. Most of us, almost all of us, were in extreme social distancing. So it will be, again, futile for me to sit in my home on my couch alone wearing a mask. Using mask would come with reopening stages. And that would be when there is community spread and interaction among people. As I mentioned in the 3 stages, the first stage carries the least risky activities. The second one would have more risky activities. The third one is the most risk. And pulling the trigger could be appropriate in the first stage, second, or third, based on different variables. In the second one, if there are multiple cases, it will be appropriate to pull the trigger on. The third one is the highest risk and definitely is the appropriate time to pull the trigger on. So why did we not pull the trigger in the first stage in May? And why did we wait until later? As soon as you implement any public health measure, physical distancing or staying at home or lockdown, there is a window of time where people would accept these recommendations and comply with them. Then you're going to find compliance fatigue and messaging fatigue. People will get sick of talking about staying home, and they will get sick about staying home. So similarly, if we implement the mask early on, we really lost the opportunity of compliance with the mask because people might get fatigued with it. Some people might develop the habit and find it more acceptable, but in general, people will get fatigued with it. And that's why it's of critical importance to wait until the last minute to pull the trigger until it is most needed. And that's why its third stage was the appropriate time to pull the trigger on. The second part of the question, how long this would last. The MOH order was issued for many reasons. One of them is a timeliness. We need to implement it, and a bylaw might take multiple weeks to be passed because the council has to meet in different times in different municipalities, and the decision might not come from a first meeting. So a bylaw was the order was implemented to buy time for municipalities to find a permanent solution, whether it's a provincial solution or a bylaw. How long scientifically we need to go for? I am cautiously optimistic there will be a vaccine that is safe and effective. And these are the two characteristics of a vaccine: safe and effective. I'm cautiously optimistic we will find that such a vaccine by the end of this year or early next year. So in 6 months from now, it's a reasonable time frame based on the phases of clinical trials that are needed to prove efficacy and safety. Then there will be the question of, after we find this vaccine, how long would it take to mass produce it and distribute it to the public? And that will be another 3 to 6 months, depending on multiple variables. But that's what our experience with annual flu is. And there will be priority for providing the vaccine to high-risk people who would suffer. However, I am cautiously optimistic we will find this solution. Until then, mask will be a useful tool for all of us to protect the most vulnerable of us. And again, if I can circle back to that question, why now? We have all been wearing a mask since March. Our mask was our house, and now we're trying to shrink it back to a smaller size to put it on our face, which is named a mask to protect the other people around us.
Thank you. That actually answered a number of questions that I was going to circle into with respect to what does the recovery look like and how realistically will we see a vaccine. So, those were well covered by that. So we'll move on to some issues around the visitors in this area. And we're seeing more and more seasonal residents in the area. Some might be choosing to self-isolate here. We might not know that, or how would we know that? And if they've been tested positive, are they reporting back to their own health unit? And is the Grey Bruce Health Unit aware of the presence of people who may be self-isolating in this area?
Yes, to all of these. So there will be visitors. We expect more people. There is always risk with a person coming from an area where there is more transmission. However, it is really not much different from the risk in Grey Bruce itself. And the health unit communicate quite rapidly with each other system to ensure everybody's followed. So there has been about 4 or 5 cases that are isolating in Grey Bruce from a different area, or they happen to be here or stay here for a period of time. And the health unit would let us know that they're coming. We would follow up with them, and sometimes both health units follow up with the person. There is no increased risk to anybody in Grey Bruce if the person is sitting in their cottage or if they're sitting in their home in Toronto or Peel or somewhere else. The risk is not different. If there is a case right in the room beside me, I have no risk. It's similar to the risk of this person is in the next city. And as long as people are following the recommendation from public health and the isolation, and we do ensure this follow-up. It's not just accepted at face value. We evaluate in every interview. We call the person on daily basis and sometimes randomly, and to ensure they are in their house. And if in every interview we evaluate compliance, sometimes there is memory issue, there is dementia, there is a person with an attitude to, I'm not going to self-isolate. So as soon as we realize there is non-compliance, we actually pay the person a visit. Our staff will have a door knock, and the police might be involved. And we have involved the police in 4 situations so far, and we ensure compliance in different ways. From that point of view, the risk to the public of a visitor or a local person getting COVID is minimized. There was a couple of cases where a person would be a visitor, just tourist, and after they leave Grey Bruce, we get a report from the other health unit that they were actually diagnosed as a case, and they were infective by the time they were in Grey Bruce. And we follow up with that case, and the health unit follows up with that case, the other health unit, and we assess the risk for residents in Grey Bruce. And so far, there hasn't been transmission with those cases that we got reports from other health units to follow up with.
I'm going to move to another important component of municipal services is parks and recreation, and I wonder if you can address plan to return to playing sports. You know, the use of the municipal amenities.
So probably that's the question best suited for Andy, who's taking the lead on that portfolio.
Yeah, certainly. So obviously with the move to stage 3, the regulation change that came with that did allow for the restart of sport. A couple of caveats that make that a little bit more challenging. It's certainly not sort of fully open. One of which it really centers around the logistics and the total numbers. So this is, I'm thinking team sports in particular. I think that's what the question was. Where either leagues need to be of a maximum of 50, or if you have a league that's larger than that, which would be typical, those leagues then need to be broken up into groups of 50. And the intent there with the regulations is to essentially minimize the interaction between teams. So you might have your 3 or 4 teams within that group. They can play each other, but then they're not to be playing teams from other leagues or other groups. But certainly that's a logistical challenge. The other big component is the sports are to not allow for physical contact. Now, the examples that were given in the framework were fairly obvious, things like wrestling, obviously significant physical contact there, and perhaps doesn't help all that much for team sport environments. So I think what we, meaning public health generally, as well as the various sports associations are trying to deal with at the moment is, you know, where does that line fall? And it seems fairly obvious to everyone that something like baseball, softball can be played, or at least modified to be played with very little risk of physical interaction, and can be done quite safely. At the other extreme of things, you know, sports such as rugby, probably very difficult to modify, and I think most people at the moment are not playing games or playing sports like that, where you've got that high, not just a high risk, I mean, physical interaction is sort of pretty essential to the game. The difficulty is those that sit in the middle, and I'm thinking here of things like soccer, and of course from the Ontario perspective as well, hockey. Perhaps not quite in the season yet, but I know this is a huge question for municipalities and for rec centres. I don't think we fully have an answer what that's going to look like yet. What I will say in particular when it comes to hockey, you know, we don't need to sort of try and work this out in isolation. We'll certainly continue to see what comes from the provincial level, what comes from the organisations, and once we've got more guidance on those, we'll obviously work with local municipalities to see what that looks like locally. And probably this might be a factor to come back to Dr. Arra a little bit, but I think interwoven with this a little bit is, you know, what the situation might look like as we get back into winter. You know, can we continue to see a movement to recovery, or do we potentially see an increase in cases and a higher risk of those sorts of things? So that is a little bit of an unknown right now, but it's obviously something that is being planned for.
I'll maybe follow up on that, Andrew, with a second question that runs into it. I know you addressed it with a number of municipalities, but their physical facilities, their children's playgrounds, and the requirements around those facilities.
Right. So, and again, obviously, children's playgrounds were allowed to reopen with that latest change in regulation. As are other facilities, so, you know, rec centres. The things that are in place are slightly different depending on what that facility is. So we sort of almost have to break that down a little bit case by case. Children's play areas can open. There's been discussion about how often can they be cleaned, can they be disinfected, and how often. And I think the reality is with those, it's essentially very challenging to disinfect most of that sort of equipment. The regulation doesn't specify whether, how often that should be done. It does talk about sort of sufficient cleaning and disinfection in all sites. I think when it comes to those sort of sites, so you're also looking at communicating what the risk is and basically reminding parents that hand hygiene before and after use is a good way of controlling that risk. When it comes to the broader recreational facilities, the total numbers of people that are allowed really depends on exactly each one. And without getting into too much detail, the gathering limits of 50 for interior spaces apply to most in terms of the individual class or room. For some certain things, conference centers, meeting rooms, and actually spectators in recreational facilities, that max actually is facility-wide, so that's actually a more conservative limit. And then there are some specific areas, pools being one, where the max gathering limit actually doesn't apply, and it comes to bather limits and physical distancing. And actually physical distancing is an overriding requirement for all those. So even if you have a maximum of 50, but your particular facility just really doesn't allow for that, then you would go with the lower number of what you can manage to maintain physical distancing.
Did you want to add anything on that area, Dr. Arra?
Well, that was complete answer all around. Thank you, Andy.
I'll move into one last area as we're running out of time. People were inquiring with regard to any comments on school openings. I can understand we're going to hear from the province today a little bit more, but public health's role and what will be happening with schools.
So school reopening is probably going to be a major item for public health for the coming weeks and hopefully not months. However, we have been working with the executive from all schools in Grey Bruce. We meet on weekly basis for the past 2 weeks, and on bi-weekly basis with all executive from all schools, and we have another bi-weekly meeting with the executive from the district schools. The plans is to have 3 separate reopening plans for each school. One is complete return of all children with all the modifications that we mentioned, and the other side of the spectrum, the other plan would be complete close down and online learning, and a third plan, modified plan, where 50% of the students will attend at one time, and they take turns alternating during morning, afternoon, or during different days of the week. There will be plenty of variability in those plans, the modified plans. We need all 3 plans because it's not going to be a decision of on, off, and not change. Rather, it's a dimmer down a spectrum of approaches. So we will start, if it's the same epidemiology we have right now, we will start with full return of students, and we will continue to monitor, and if there is any change in the dynamic of the outbreak in the community or outbreaks in the school, we would modify to one of the 2 other plans. I have no doubt we will see sporadic cases going forward, whether it's in the community or schools. However, if we do our work right, our job right, all of us, we will not see outbreaks. So there will be sporadic cases. All in all, I do believe the good work that all of us have invested in, by we and us, I mean the collective societal we, the public health recommendations and teams, the public, local political leaders, government levels, all of us have done a really good job to ensure safe reopening for the community and for our kids.
Thank you, Dr. Arra. I'm cognizant of the time, and we're down to the last couple of minutes. I wonder if there's any closing remark you'd like to make.
I just want to thank everybody again for being engaged, concerned, and knowing all the facts that you need to ensure reopening safely. And I really boil it down to the 3 W's. Watch your distance, the 2 meters, wash your hands quite frequently, and wear a mask correctly and in a correct way. These are the 3 things that are going to carry us through the coming months. And as leaders in your organizations, you can implement it in many ways, whether through policy or through practice, or most importantly, through example. And I have no doubt we'll be able to iron out the challenge in front of us, similar to the way we have ironed out the mitigation part that we dealt with in March and April. And thank you for all.
Thank you, Dr. Arra, and thank you for everyone joining us on this Zoom event. As I stated at the outset, it's been recorded and it'll be posted on the Grey Bruce Health Unit YouTube channel. Didn't see any questions come up in the chat, so any additional or unanswered questions can be focused to our Contact Us page on our website, and we'll respond directly to all inquiries. Email again is publichealth@publichealthgraybruce.on.ca. And before we close, I want to thank Bruce County for bringing together the participants in this section, and thanks to Sandra for facilitating. And with that, a final thought from Walt Disney. Why worry? If you've done the very best you can, worrying won't make it any better.